So the next
How
speaker
are you?
is Manjul Tripathi. Are you ready, sir, to go ahead with your talk on stereotactic radiosurgery for spine tumors?
Well, very good afternoon, and thank you to the organizing committee, especially Professor Ramani and Professor Sahu, for giving me this wonderful opportunity. I believe I might stir some controversy with this talk, but still feel it to be considered worth giving a thought. I will talk about our experience with the two cases of upper cervical spine IDM, which we treated with gamma knife radiosurgery at our place. So, this study was actually a brainchild of late Professor Kanchan Mukherjee, and it got published in Acta Neurochirurgica. Traditionally, in gamma knife, the lower lip of the foramen magnum is the lowest limit of the treatment. However, in few publications, it is acceptable to treat lesions even up to the upper border of excess vertebra, considering the limited chances of any movement in that zone. So, before talking about it, I would like to tell that spinal radiosurgery is an extrapolation of the cranial radiosurgery. And when we talk about radiosurgery, it's a precise focusing of the multiple beams of low energy. This is a high dose in the target volume. So if this is your target, only this area is getting the maximum radiation, and there is a very sharp dose fallout with a very steep gradient. So only you treat your target area, and for that matter, your target needs to be well delineated from the surrounding tissues. So it's good to treat a metastasis, but not too good to treat a glioma, because glioma infiltrates into their surrounding tissue, but metastasis gives you a sharp demarcation. With that same principle, because the cranial radiosurgery is now a 6 decade, or you can say 5 decade old technique, it has now been extrapolated to the spinal radiosurgery, and the results are really good. So, when we talk about gamma knife radiosurgery, when we attempt to target lesions at C3 or beyond, the major practical obstacles are difficulty in the frame fixation, avoidance of the collision, and immobilization. Because immobilization is an integral component of gamma knife radiosurgery that directly affects the accuracy of the treatment. You need to be precise, you need to be effective, and you need to work like a surgical strike, not like a full blown war. So, we were not the first to realize this problem of difficulty in immobilization, and the leading groups were already thinking over it. Lunsford and the group tried to examine the relative movement at different cervical joints at different gamma angles, and they found that movement at C3 and C4 is actually 6 times higher than the movement at occiput and C1. So, as we go down in the cervical spine, the range of movement is non-acceptable. We need to remember the fact that when we talk about gamma knife, we look upon something with great respect and confidence as far as precision and accuracy is concerned, unparalleled to any other radiosurgical tool. And when the chances of error are in the range of 4 to 5 millimeter, that purpose is lost. So we tried to treat it in a protocol-based fashion, only for patients with the tumors away from the spinal cord. We tried to evaluate the patients if their neck was long and head was short, preferably microcephalic. We ruled out any CVJ anomaly or any maxillary fracture. We removed the top frame of the MR indicator, checked all the collision to minimize the movement in the upper cervical spine. We maintained the glabular floor and the sternal floor distance. All shots were at 90 degree, and the neck was immobilized with the Philadelphia collar, and the pillars of the frame were jammed over it. So this is the collision frame, which we need to ascertain that we are not injuring, we are not hitting any structure in the gantry. And this is the bubble measurement frame, and there are different heights and different lengths over it, and this becomes the skull measurement sphere and the distance from the top of the helmet to the setting point of the Lexel G frame, that is 17.15 centimeter. That becomes a limiting point over here. So the first patient was actually a female with a residual meningothelial meningioma, which was extending from the lower margin of C1 to the upper border of C3, and it was away from the spinal cord. She was an operated patient, and her neck was actually immobilized with a Philadelphia collar. We jammed the pillars over it, fixed over the maxilla and posteriorly. So it's a 4-point fixation. This was the tumor which was extending into the upper cervical spine. The second patient was actually a case of residual neurofibroma of volume around 4.12 cc. You can see here that the MR indicator cap is removed so that the MRI can be done. And this was his lesion, which was away from the spinal cord and going down. Both the patients tolerated the procedure well without any complication, and at now 2 years there is no problem with their treatment, and the lesion has also radiologically reduced in size on a comparative evaluation. So to ensure the lowest possible frame fixation with no collision, length of the neck and head of the patient needs to be assessed. There is a fundamental argument of the lack of immobilization with the cervical spine or lower down in the spine, because even with the physiological movement like the deglutition, respiration, there are chances that the cord may move. Hamilton Lulu obtained a target accuracy of 2 mm in the transverse and less than 4 mm in the vertical plane with a frame fixation to the spinous process. But this remains unacceptable to Gamma knife because Gamma knife provides you a submillimetric accuracy. To maintain the same, we jammed it with a Philadelphia collar and we maintained the same length, same gamma angle to minimize such complication. All shots were at 90 degree. The basic laws of force and motion state that longer the distance between the fulcrum and the lever, more is the displacement, absolute displacement. Bringing down the screws from the supraorbital to the maxillary reduces the lever length. So this length above the base plate is reduced when you put it over the maxilla, and the chances of the relative displacement are also reduced. In a similar fashion, the chances of relative motion increases for a peripherally located lesion compared to the lesion which is located near the central canal of the spinal cord. So there are limitations, especially with the physiological movements. We cannot totally nullify the respiratory movements and movements of CSF flow, though they must be in some millimetric range. But when I am talking about the precision, this fact cannot be ignored. So, and there is a problem with the radiobiology because the standard dose algorithm for gamma knife is based on the assumption that the absorption of the radiation is the same in the water as in the brain, and this cannot be extrapolated to the cervical spine. This limitation at this juncture is difficult to circumvent scientifically. The dose response rate at this time is empirical, and more studies with the better software and follow-up are needed for the spinal follow-up. This was published and received a very good applaud and letter to editor. To circumvent the same problem, to reduce the immobilization, to reduce the movement for the lesions extending beyond, especially at the areas where there are chances of movement like the temporomandibular joint, we go and furthermore we try to put the brackets over the teeth and do a jaw immobilization for the lesions which are extending into the upper cervical spine and the temporal area. So to conclude, when you look over this treatment modality, we find that the basic argument is lack of immobilization, which can be curtailed to some extent with Philadelphia or Minerva jacket and the frame fixation down, minimizing the chances of the complications. Thank you. So let's now come to the second part of the talk, and that is radiosurgery for the metastatic spinal tumors. And I would like to quote Henry Marsh over it. The most difficult part of my job is not to make surgery. The most complicated is to decide to make it or not and live with its consequences. So in 2005, the Petrel trial got published and it changed everything. It provided a class 1 evidence to support the initial treatment of the spinal cord decompression with postoperative radiotherapy, which was found to be superior in comparison to the one which have been treated only with radiotherapy alone. So patients started getting referred for the surgical evaluation again. And once we got the approval, we performed major and the morbid surgeries, but they came with a price. Most of the cases did not enjoy a longer term survival and the pain-free period. So to evaluate what is the spine radiosurgery as an extrapolation of the cranial neurosurgery, radiosurgery, it is a radiosurgical procedure with a high dose per fraction radiation. In a single fraction, it might be 14 to 24 gray, or there are various hypofractionatory regime. The core principle is to provide a cytotoxic dose and ablative tumor dose while sparing the normal tissue tolerance. And that's why it is very important to choose your target carefully. It should be a well-defined lesion, like a metastasis, like a chordoma, but not like a glioma. The principal applications to the spine are primary treatment for the resistant tumors, re-radiation following failed external beam radiation therapy, postoperative adjuvant therapy, neoadjuvant therapy for the primary tumors. And similar to the cranial radiosurgery, you need an accurate identification of the target and the surrounding normal tissues, sophisticated treatment planning with a sharp dose gradient, reliable near rigid immobilization, image guided verification to give you a submillimetric delivery of the radiation. The current literature strongly supports the role of radiation therapy in the management of spinal mets and the tumors, and the literature is growing day by day in support of the stereotactic radiotherapy, radiosurgery also. When you consider conventional external beam radiation therapy, there is no difference in the outcome between an 8 gray in a single fraction and 4 gray in 5 fraction for the metastatic epidural spinal cord compressions. But the adverse events after conventional radiation were pretty high, with a cumulative incidence of radiation-related acute side effects were 24% at 180 days, and they increased with the spinal instability and the single fraction therapy. When you look at the overall clinical outcome for SRS, this is the Pittsburgh group. They found a long-term pain improvement in 86% patients, with a radiographic control in 90% patients, and the clinical improvement after progressive neurological deficit was found in 84% over a decade-long experience. So in last 2 decades, there has been a growing number of evidence and recent acceleration in our knowledge about radiosurgery and its role. The current recommendation is radiosurgery is safe and effective with a durable symptomatic response and a local control for even radio-resistant histopathologies. That is actually the catch. You do not need to be worrying about the radiation sensitivity. It can be a melanoma, it can be a prostatic cancer, it might be a breast cancer, and it might be a completely radio-sensitive tumor. Radiosurgery should be considered over conventional therapy for the treatment of solid tumor spine metastasis in the setting of oligometastatic disease and radio-resistant histopathology. Now we have an RTOG guideline with a class 1 evidence in support of the spinal radiosurgery. They compared 16-gray radiosurgery for oligometastatic disease with external beam radiation therapy, and these patients were followed up on the clinical radiological profile and the pain scores and the quality of life. In those cases, they tried to give a dose constraint to the spinal cord in a single session. Not more than 10% of the spinal cord volume was exposed to a 10 gray, and it was limited to 0.35 cc. Now these studies have shown that they provide a good local control of 84% with no high grade toxicity, no compression fractures, only in 4% cases. If the patient has previously received radiation and there is a new tumor, a repeat radiosurgery can be safely and effectively performed, though they may need a fractionation, hypofractionated in 203 with a local control rate as high as 70%. There is no clear advantage of 1 versus 3 or 5 fractions, and sometimes you need to fractionate in 3 or 5 fractions because of the different histopathology and to be radiobiologically beneficial, and that needs to be discussed on a case-to-case basis. It provides a significantly better rates of the local control. So, you need to adopt to the spinal radiosurgery, and there are parallels with the cranial radiosurgery by giving a very good precision, accuracy, avoiding an open surgery, altering the natural course of the disease, and integrated into the systemic therapy. But at one place it is different from the cranial part because you need to take into consideration the issues of the spinal instability. And if such kind of an issue is there, you can combine it with your surgical techniques with the vertebroplasty, kyphoplasty, with the percutaneous fracture stabilization and giving the radiosurgery, and it would serve your all the purpose. It would give a good stability, provide a mechanical pain control and the tumor control. So it would serve in a very short duration of time both your purposes. Combining surgery and radiosurgery, does this strategy work? Yes, it definitely works, and it gives a long-term good outcome. So radiosurgery in the case of spinal mats is a paradigm shift, especially it is for the oligometastatic and the radio-resistant sort of tumors. And the literature is gradually getting improved and improvised with the role of the radiosurgery and in the spinal cord tumors for both for the benign and the malignant pathologies. As far as spinal cord tolerance and complications are concerned, spine radiosurgery when properly done is safe. The tolerance of the healthy spinal cord is likely to be a 10 to 12 gray per session to the small volumes of the cord, that should be in the range of up to 1 cc. So to conclude, spinal radiosurgery is safe, clinically effective and feasible for both benign and malignant pathologies. Its major potential benefits are shorter treatment time in an outpatient setting with minimal risk of complications, and it is an alternate treatment modality for various benign and malignant pathologies where surgery cannot be performed in patients with previously irradiated sites in cases involving lesions not amenable to surgical techniques, and as an adjunct to the surgery. To summarize now and to conclude, radiosurgery has become an essential tool in the multimodality treatment for the spinal cord tumors. You need to be like this frog or like this alligator to carry this team with you to tame your target. Thank you so much.